examples, you have always to say, I'm not doing that because I think I could directly import the example in the system in which I am working at the time. It's even more true for the US. This is something, as again, that I've been invited to talk about very often by Steward of Change. You know, the US is really exceptional, and there is no country in the OECD that have this gap between health and social policy. And of course, as you know well, we have discussed that yesterday, and we have heard about this this morning as well. In the US, the gap between health and social that exists everywhere is amplified by structural issues like racism and poverty. Again, in ways that are experienced elsewhere, but never at the same degree. And it makes your situation really, really, really unique. The other big difference is that, as you know, probably all the other countries have all, to a degree, some sort of public health system, healthcare system. So care is provided more or less free of charge to people, which and we have seen that during the COVID crisis. It makes a huge difference at this question of access to healthcare. So it means that in most countries, when we're talking about health and social policy, we're mostly thinking, how do I expand the range of services that I'm providing within my public system? Or how do I better integrate the different social services that I'm providing, social care that I provide with my public health system? Again, it's very, very different here. I think the way I see the conversation this afternoon, because it will be a conversation, it's mostly to see how could we expand the boundaries of what we think is possible. How do we learn from other countries' experiences in terms of implementation, in terms of challenges that they have met, and they are still meeting. You will see that in our presentations this afternoon. The challenges that everybody is still facing when they are trying to get this better integration of health policy and other areas of social policy writ large. We will hear about Europe. There is Finland is probably one of the countries at this moment that is really the poster child of successful integration. We will hear about an example that I will present with one of my colleagues around Alberta, which is the province where we both live at this time. And that will give you a very grounded example of what is possible when you have a public healthcare system and what is still to be done in a system like this, showing that this is not a magic bullet. It solves only one part of the equation. And finally, Dave, who has this panoramic view of what is happening in emerging economies and developing countries, will help us better understand, what we could learn from all those countries that are at this moment trying to do the same, of achieving this degree of integration. And again, what are the lessons for the United States and people working in the system here? Maybe what we should do is, and I could do that myself, I believe, remind you that, what we want is frame the conversation. I could do that even better, I think. I could do that with, you see, it's, show you the recommendation that have been developed throughout our process in the last months. Again, because I think it's important to frame our conversation around those recommendations. So I will go very quickly around this. You have heard them a few times now. Number one, housing, work to make housing an explicit integral element of healthcare in policy and practice. Data sharing and integration, demonstrate and document that data sharing could occur across diverse services and sectors. Civil justice, collect data to understand user experiences with the civil justice system I can't even see the word now, to improve accessibility enabled through technology, care coordination, identify a guidance and support framework that outlines good and best practices, recognize the ROI, and includes an adaptable and replicable means for cross-sector sharing, governance, identify or develop a governance model that enables policy formulation, decision-making processes and organizational principles, and finally, lived experience, incorporate people with lived experience at all levels throughout organizational and governmental programs and systems. And you will see in the examples we have chosen that all those dimensions are already present in the presentation. So what I suggest I do now is that, do you have, Grace, have you heard back from Alfonso?
Alfonso is on the call with us.
Is excellent. So I think the first thing we will do is that we will go to Alfonso for his presentation.
Okay, I'm going to share my screen now then.
Okay, please do.
Good evening, everyone. Thank you very much, PG. Can you hear me?
We can hear you very well, actually.
Lovely, excellent. Well, thank you very much, and good evening, everyone from Europe, from the south of Europe, actually. And it's a pleasure to be here with you today in this National Action Agenda Symposium with all of you, Steers of Change. It's great, really, that we are gathering here to colleagues from Europe and from the United States to talk about care coordination across sectors. I'm going to try to give you an intro to that with some perspectives from Europe. And
did he freeze, or is it just?
Yeah, you look frozen, Alfonso.
Oh boy.
I would like very briefly just to let you know about ESN. ESN is a network of public authorities in the field of social services. And we've got around 150 member organizations in 36 countries. So we are a network that brings together policymakers, researchers, and others in order to try to basically influence, inform and influence policy developments in the field of public social services. Can we move on to the next slide, please? Oh, there seems to be an issue with the presentation. You want me to?
Grace?
Yep. Now it sounds like I froze. Let me try. There we go. Can you see the screen now?
Yeah.
And you could move in presentation mode. Yeah, excellent.
There we go.
Oh, lovely. Excellent. Well, if we can move on to the next slide, please. So yes, the starting point that I thought for this presentation was to look at this family that I think everyone knows is a family like any other that has a series of problems and problems the social services deal with on a day-to-day basis. It can be someone who is unemployed, someone who has problems to be able to access employment because of having children and not having enough childcare. There might be issues when it comes to housing, to be able to access decent housing for their family. There may be problems for children in school to be able to access activities in the afternoon or to be able to pay for their trips or cultural activities. And this is where the vision of care coordination between the different professionals who are working with this family comes into play. So moving on to the next slide. What do we mean when we talk about integrated care? Well, when we talk about integrated care in Europe, we might mean different things. We might refer to ways of improving cooperation between different professionals coming from different sectors who, of course, work with the same person or the same family. We may be talking about reorganization of structures or improved governance of the different organizations involved in providing that care. We might be talking of integrating various strands of financing by pooling budgets in order to be able to pay for those joined up agencies. In one way or another, they are all integration, but the question is whether they are actually improving outcomes for the people they intend to serve. So moving on to the next, slide. moving on to the next, I don't know if Grace.
Okay. Now I'm having system issues.
There are some issues with the next. I'll try to continue, and then if not, I can try on. Yes.
That work now?
Yes, lovely. So I just try to give you a definition of what we mean by integrated care. In general, when we talk about integrated care, we talk about initiatives that aim at improving care by overcoming fragmentation, because traditionally this type of care has been provided by different sectors. Each sector had their own responsibility, through linking or through coordinating services and providers throughout what we call the chain of care. This might be done at the strategic macro level in terms of planning. It might be done at the level of the providers themselves, where providers might seek to deliver integrated care for a particular group or population with the same conditions. Or it might be done at the micro level, where the focus is on the delivery of that integrated care for the individual user. Now, some examples, if we move on to the next slide, please, some examples in terms of practice. We might be looking at integrated care in terms of case management, meaning that a person or a family has a case manager, a professional of reference that is responsible for making sure that this family can access the different services that the person or family is entitled to based on an assessment of needs. It might be a one-stop shop, which means an entry point of ensuring that the person or family accesses the different services. It might be that two or more organizations join up in a specific partnership, in some cases also by pulling together their budgets. And finally, multidisciplinary teams, which are probably one of the most widespread examples. And moving on to the next, slide, you can see some examples of this. Of course, a vision for integrated health and social care existed many years ago. Back to the 50s in the UK was probably one of the most advanced countries at the time. But actually, nowadays, social workers work alongside health professionals in integrated teams. For instance, England's Home First teams try to work together, different professionals work together to ensure that older people can remain in their own homes for as long as possible and delay that they enter residential care. Or centers for older people with long-term care needs, where you've got, in France, where you've got a primary care doctor, a community nurse, a social worker, and other professionals working together with people with long-term care needs. It might extend over health and social care to include, for instance, the police, education, social services, health, and community groups, as it happens in the early years collaborative in Scotland, in the UK, or in the Spanish regions, you've got also networks for early intervention with children with developmental problems. And there you've got one-stop shops where different professionals, whether social educators, social workers, doctors, and others work together with those children. Now, moving on to the next and final slides. When it comes to integrated care, there are both opportunities, but there are also challenges in terms of implementation. The opportunities come from the opportunity to be able to jointly define objectives and values, to be able to work together with professionals across different sectors means that there is the possibility to foster cooperation and also innovation and develop jointly training together. The importance of the case manager is actually probably the figure most recognizable when it comes to integrated care as the professional of reference, both for the persons, but also for all the professionals working with the persons themselves. And we do have evidence that many of these programs, when it comes to integrated long-term care, they do reduce the numbers of admissions into hospitals. But of course, there are a number of challenges as well, particularly when it comes to the lack of communication between professionals from different sectors, Integrated care does require investment for the workforce, and this is well, in a context right now, in particular, of constrained resources. Integration, in some way or another, could also lead to reducing choice for service users, particularly if you've got providers coming together from multiple agencies, multiple services into one joint up service. And it's also important to recognize that evaluation should not only look at quantifiable indicators, process indicators, but also look at qualitative outcomes-based ones around the satisfaction of people using the services, their welfare and well-being, and more broadly, their quality of life. So all in all, moving on to the next slide, is important not only to look at integrated care, but to move towards person-centered and person-led care, where the different professionals working with the family work together to ensure that that care provided in an integrated fashion improves persons and people's quality of life. Thank you very much. If you have any questions, don't hesitate to ask.
Alfonso, thank you. That was brilliant. Thank you so very much. Next, I think, is us. I mean by us, Nicole and I. I am sharing. Oops. I need to share my screen to do that. And to go back to this. Okay. So what we are, I'm sorry, I'm trying to get a smaller image, and it's always difficult with Zoom. So what I will do, we want to talk about a Canadian example now, and the actual work on the ground has been made by my colleague Nicole Morin that will present the actual case. I just want to say a few words of introduction to the actual case. You know, the Washington Post journalist T.R. Reid, former journalist T.R. Reid, said once that Canadian healthcare is like American healthcare, but for free and with a delay. And in fact, it's probably unjust because we have been paying attention to the social determinants of health in our policies for probably a longer time than many countries. The federal government has the doctrine around determinants of health since the early 1970s. The problem in Canada is that the influence of what the federal government is doing on the provinces who are actually responsible for delivering care and delivering social services has been quite limited. So on the one hand, there has been a discourse around social determinants. It has been part of the policy conversation now for 50 years. But when you look on the ground, it's much more complicated because even if we have seen limited provincial and local initiatives, there have been very few things that I could claim now are real successes. And you will see the type of challenges we're facing in the example that we have studied. As I said here, it's better than nothing because again, there is a legitimacy of addressing those issues in policy conversation. And what has happened recently with COVID is the sense that it has revealed the incredible vulnerability of some parts of the population, either because of social conditions or because they are racialized communities and so on and so forth. So I am predicting that the discourse around social determinants will become important again when we will get out of this crisis. So the case Nicola will present is a case in the province of Alberta, and I think it's very telling of what we can or cannot do. Nicole?
Can you hear me?
Yeah, now we can hear you.
Oh, okay, perfect. Sorry about that.
Okay, I'm going back to this. And you should be seeing my screen at the same time.
Yes, I can see it.
Okay.
Okay, great. Excellent. So yeah, as PG said, my name's Nicole and I work as an occupational therapist in the inpatient setting at the U of A hospital here in Alberta, Canada. And I work on a multidisciplinary team, a nephrology team working with kidney care patients. And my role within that team is to work in collaboration with other team members as well as a physiotherapist to provide various forms of rehabilitation to patients, to make recommendations on adaptive equipment, and as well as to assess patients' functional capacity, both mental and physical, to be able to take care of themselves and manage in their communities and carry out their day-to-day activities in the context of their disease. And I tell you this just to give you an idea that as an OT, I'm trained to have a very holistic perspective on patients and their needs in relation to whatever disease that they do have. And so as I previously mentioned, I do work with kidney care patients, and this includes patients with end-stage renal disease, as well as patients requiring dialysis and ones at risk for further development to end stage. And this is a population that we've chosen to highlight as this population, first of all, I deeply care about this population. I've been working with them for a significant period of time over many years. And this is a population that is specifically socially disadvantaged in a very socially vulnerable group whose social determinants play a really large role in their overall health and well-being in general. Yeah, so like most chronic diseases, patients with kidney disease are very medically complex. Typically, they have other chronic medical conditions and comorbidities that they're dealing with, for example, diabetes, cardiovascular disease, as well as amputations often as well. These are patients who require support from both the healthcare system and the social sector, and whose service needs cross both sectors of government. So for example, due to the disabling nature of their symptoms and the burden of their disease, many patients are unable to work or are only able to work at reduced capacity, for example, and obviously not being able to work results in less income, and the burden of this disease incurs several costs associated with medication and treatment. Yeah, and overall financially puts them at a very high risk for poor outcomes. Most of these patients do receive some level of social supports or financial benefits for their disability, in addition to the healthcare services that they receive. So applying for social supports and navigating these social support systems can be very complicated. And while dialysis and in-clinic and in-hospital care is publicly funded, actually getting to treatment, to see providers can be very expensive. And so other incurred costs in this regard can include things like transportation costs, accommodation, and obviously the expensive medication regimens as well. And if patients don't live close to a dialysis center, then they must move closer in order to receive the treatment. And it's also important to mention that the costs of maintaining a kidney healthy diet is also extremely costly. And most of these patients are encouraged to follow this diet, and not to mention that in general, adults with kidney disease experience higher rates of food insecurity in general than the general population. And obviously food insecurity further is further associated with poor health outcomes and things like that as well. And so I guess the picture I'm trying to paint for you is that these are very, very complex patients. And you know, there's this bi-directional relationship where a lot of patients who develop chronic kidney disease actually live in low SES areas and experience poverty, while at the same time, due to their disease, they're at a higher risk for becoming even more impoverished because their inability to work, et cetera, et cetera. No, perfect. Thank you. So what can be done, I guess, to better provide our patients and these patients with, to better meet their needs? And so I guess one of the benefits of having a single health authority, so Alberta Health Services in Canada, well, in Alberta is what we have, so it governs all of the healthcare resources in the province. We do have the opportunity to realign resources to better meet the needs of our community. And of course, meeting the needs of any community or population means having a complete understanding of what those needs are. At an organizational level, Alberta Health Services has done a fantastic job at developing and implementing kidney care pathways for patients in terms of managing and coordinating dialysis, and creating a provincial registry that tracks patients who are receiving dialysis and are followed by a nephrologist. But despite having a relatively integrated pathway in care for these patients, there's still patients who are experiencing barriers to optimal care. And these barriers are, as I previously mentioned, are related to services outside of the direct medical care that they're receiving. So reducing barriers to accessing care for these underserved patients can range from numerous approaches. For example, providing patients with cost-effective transportation, making it easier for them to get to dialysis, identifying language barriers, things like that are also extremely important. At a practice level, interventions and broader system change are important to promote, more health equity for these patients. Primary care is another area that can also be included in the realignment to better serve community-based care. And there's also a lot that can be done at the patient provider level too. So for example, a lot of research that I've read and is speaking directly with primary care physicians, there's often a lack of knowledge around problem-specific referrals for patients in the community. So a lot of physicians don't necessarily know how to connect patients to income supports, housing, food insecurity, for patients that are food insecure, connecting them with resources like that, as well as transportation resources. And this is where community multidisciplinary care would be of benefit to these patients. Similarly to how we provide care in the hospital, it's extremely comprehensive. The same type of model of care can be mimicked in the community as well, which would also provide these patients with, more comprehensive resources as well. And then, as PG mentioned, COVID-19 has also made it possible for providers to deliver care without geographic restrictions necessarily. So interdisciplinary dialysis teams can also adapt to provide these virtual types of visits. We've seen a lot of expansion in our virtual healthcare provision, like in Alberta, and this type of service can also be expanded and built upon to provide care for these complex patients that have both social and medical vulnerabilities. Even if we have a robust community multidisciplinary team, there still exist challenges of providing services to particularly isolated and hard to reach patients who require more integrated and proactive approaches. So virtual health and telemedicine provides that opportunity to really deliver care in a way that's specialized, but also doesn't necessarily, can also take into account the kind of the geographic disadvantage that some of these patients do face. Yeah, and so I just also wanted to mention that in addition to telemedicine and virtual healthcare, Alberta's in the process of rolling out an EMR, which we call Connect Care, and it's shared amongst all hospitals, community care clinics, home care services throughout the province. And the rollout of this EMR is taking place over the next 2 years. And what's really exciting about it is the opportunity and doors that it opens to help us provide more seamless and information sharing across these patient populations. And it also have the potential to improve communication, obviously, between providers, as well as communication with patients, as there is a My Health Alberta link adapted into that, so patients can go online or on their phones or and actually access all of their own information as well, and communicate with healthcare providers in that fashion as well. So that's another way that we're working towards really reaching these socially vulnerable groups. And lastly, in addition to providing a more robust community approach to treating these type of patients, it's also important to meet the needs of patients where they're best suited, which is definitely not in the hospital. At that point, we really failed to meet the needs of the patient, in my opinion, once they end up in the hospital. So providing home modalities, whether it's expanding home dialysis and those type of approaches are also going to be extremely important as well. Next slide. Oh, and so yeah.
Already on the next slide because time is flying.
Okay, I'll go a little bit faster. So yeah, so these are all great ideas. Obviously, a lot of this information isn't new, and we've talked a lot about this throughout in other presentations. So you know, what are the challenges associated with everything I just said? Well, there's the lack of accountability with the social determinants of health. You know, a lot of providers do care a lot about social determinants, but there's really that lack of leadership amongst from an organizational level and with above the organization and within the organization, from government and within the actual healthcare sector itself. Funding is another huge barrier, I guess. The financial incentives for physicians and the funding models are currently not aligned with supporting social determinants of health for Alberta, in Alberta at least, for chronic disease patients. The fee-for-service model doesn't necessarily promote social determinants of health, but rather promotes volume of patients seen, and that's another barrier that we're still facing here in our province. And then again, just the lack of shared leadership between disciplines and between the healthcare sector. And then again, all of these ideas sound great, but if they don't meet the actual needs of the patient, and if they can't access, you know, what computer devices, the technologies necessary to implement some of these strategies, then that's going to be another barrier as well to providing these patients with adequate social and healthcare services. And that's everything.
So, thank you. What I suggest is that we go directly to Anu. I'm conscious of time, and so I'm trying to expedite a little. Yeah.
PG, it's Gillian. They extended the time to 3 o'clock.
Excellent.
Yeah.
So we'll have time for questions and the like, and thank you so much.
Yep.
Anu, you could share your screen.
So you can't see it now?
Yep.
Here.
Excellent, beautiful.
Yeah, so good evening everyone, and it's been great to hear your presentation so far. As BG said, that if this integration and interoperability would be, it would be easy if we could just copy it. So we would have done this years ago, but we have been struggling with the issues here in Finland, despite that our system is, we are really proud of it, but still we have a lot of things to do. I started my work career as a case manager over 20 years ago. And at that time, I really believed that case management was the answer. But as years go by, you see that there are not only one solution to these problems. Not the army of case manager will save anything if your system is scattered and there are barriers and you work in silos. No case manager can overcome all those barriers, but we need to develop things in really many levels. So here, even though Finland is the happiest country in the world, third time in a row now, and we are proud of it, and existing explanations, there is the welfare state generosity. We have really trying to work that our incomes are equal, and there are no polarization between people living here, and we are like happy with our institution, but and it includes the integrated public care, which is available to everyone for free, nothing's for free. We have a high taxes here, but basically everyone has a possibility to have healthcare and social care. But still, one corner of this integrated care which has been missing here is let me show you first this one. These sort of levels that I've been working with. I've been trying to, as I said, that case management wasn't the only answer. We need to see all the levels here so we can have the entity straight. So at the moment in Finland, we are doing for, I think it's the 4th time now, we are trying to do the legal interoperability. So the legislation wouldn't prohibit us to do good things for our patients. We are in Finland, social care, primary health care and specialized care, they are really in different silos. I think this is the issue in many countries. Also, the organizations in those silos are scattered. We have municipalities which are organizers of these 3 sectors. So at the moment in central Finland, we have 23 different municipalities which are they are organizing by themselves the social care and the primary health care and the specialist care. There are a lot of barriers when you think about client perspective. Then we are working on then governmental interoperability and integration, that we have only one organizer, so we could have monetary fundings are integrated and everything. But when all these are done, then we can go the technical interoperability. And as Nicole said, we have some kind of a project going on in these 4 areas in Finland with Cerner, and which is providing the Millennium healthcare EMR, and then IBM is providing us the social care part of our integrated client and patient information system. So it will be connecting to 25,000 professionals in this area. We have six central hospitals, bigger hospitals in the area. You see the numbers there. So nowadays we have over 300 different IT systems in our area. So that alone will help us to communicate better, to see the patient's work, patient flows. It helps us to see the entity of the patient's paths. So nowadays we are kind of optimizing that. If I look the patient's path from my perspective, I optimize it from my point of view without thinking about the next who is giving care or treatment to the patient. So we are really believing in this cooperation with the Cerner and IBM and Hygge. It's a Finnish dental care company there. So that's a big effort which is going on. Then I like to just point out why integration, why is it so important here? We all are looking at the integration from the same perspective. I think that it is not shocking news to anyone that if you don't need to go over the bridge, it doesn't matter if the bridge is broken. So if I only need the primary health care, it doesn't matter if the professionals between specialized care and social care, they don't talk to each other. I just need the flu antibiotics or something. It doesn't matter if they don't connect. But we have done studies here in Finland a long time ago, which were hand-picked because we don't have the common IT system which would give us this information. For example, this is also internationally known that maybe 10 or 20% of population is using 80% of our resources. So here's the small picture. It's poorly translated by me, but I tried to explain that why integration is that when you see the the 10% of our population, which are using the 80% of the resources, when you dig a little bit deeper, you see that the biggest reason for that is that the 5% are using or needing both health and social care. 60% of people, there are elderly care, child protection, disabled services, substance abuse, psychiatric, things like that, and we can't afford losing that information. We cannot work by knowing this and do the things in silos anymore. So there's a little bit, I don't go so deep to this, but for example, the middle colorful boxes there, the most expensive 10% of population, each of them uses averages 4 services, which they are using, when the rest of us, I could say, we use only 1 or 1.1 services each. So difference is huge. So we really need to focus on this 10% too. So we could, and I really believe that by this new information system we are developing, it is one answer to give better treatment, to focus our services and give better treatment people. So as I think it was Nicole who said that it's too late if we meet the patient in hospital. We could have done so much advanced. And one of the focus areas in our project is to shift the focus to a little bit earlier phases, not recovery phase, but the early phases. So, but there's a lot of going on in Finland. It was hard to focus after yesterday and today's presentation. I already started to think that I need to rewrite my presentation because there were so many things that I would have liked to have discussions with you. But shortly, this is something that is happening in Finland at the moment. Thank you.
Thank you so very much. Fascinating. Dave, the conclusion.
Yes, well, hello, everyone. I'm speaking to you today from Atlanta, Georgia. This is where my organization, the Task Force for Global Health, is located. Very briefly, I think I'm involved in this particular conversation for a couple of reasons. One is that my work over the last, I don't know, 30 plus years here in the US has largely been around the integration of public health programs through better informatics. And that's actually how I came to know Daniel Stein. But for the last 20 years, I've been at the Task Force for Global Health. We are an organization most of you have probably never heard of, but Forbes says we're one of the largest nonprofits in the country. And the reason is that we work in 157 countries. And every year we directly touch the lives by putting medicine in the mouths of about 500 million people. And we do that through partnerships. So for these reasons, I think I've become involved, but it's given me a different kind of a perspective because we work largely in low and middle income countries. And that's a very different perspective. So I want to make several observations on what we've just heard and what I think it might mean to this larger collaboration here for interoperability. You know, Alfonso talked about service integration and how really is that defined. I must say, I'm so impressed at the number of people or number of countries, Alfonso, that are in your European network. That alone is an example that I think we need to bring to the low and middle income countries because they are looking for ideas and directions forward. And just the fact that we can bring a group of policymakers and researchers together to look at this complex problem is itself a step forward. And I really thank you for what you do, but also for talking about and explaining it, because I didn't know about it. And my work, because we are we are an official non-state actor of the World Health Organization, which means we have a seat at the World Health Assembly and an opportunity to put forward recommendations to the World Health Ministers. So keep in mind as I talk, that's a role that my organization can play in helping advance this thinking. And I think the idea that Alfonso talked about linking and coordinating, integrating this number of countries into the network, that's wonderful. You also mentioned, we don't have time to go in great depth, but this is something we work on a lot, is an impact financing model. With a number of our funders, what we do is built around measured impact. It's not about process, even though process is hugely critical and important because changing outcomes takes years at times. But measuring the changed outcomes is a critical part of our models. And in fact, that's the starting point with both all of our funding partners and all of our expert technical committees is we start with where are we on the curve of impact? If we're trying to eliminate a disease, how much progress have we made in the last 6 months? And then from there, we get to the process stuff. But it's always kept, that what our real final mile goal is always kept front and center. Nicole and PG, your example on chronic kidney care is also, I think, very, very enlightening and helpful, both for its practical example of comprehensive community care and the need for it. And you spoke directly to this idea of culturally and socially adapted tools from the world I work in all these different countries. That concept is put in our face on a daily basis. So it's really, really important. And in Finland, Anu, you talked about sort of overcoming these silos within silos, and it's inevitable in the kind of work we all do that those silos start to happen. But confronting the 80-10, 80-20 problem is that financial rationale that I would like for us to think a little bit more about. And I certainly, as we enlarge this dialogue of interoperability to middle-income countries that are striving to build health systems, this is an issue that we need to put in front of them. So let me just take a few minutes. Thankfully, we did get a time extension, but to tell you something that I see happening in the countries where we work, and why this discussion today is so important. There are a number of mid-tier countries that are seeking to develop national health insurance schemes, but they are, in my view, making many of the steps towards having a problem that we all are trying to confront. They are going straight at medical care directly, very often thinking in terms of a national health insurance scheme like Finland, or like many European countries have of some form or other, but approaching it in a fee-for-service basis. So what that tells us, they will drive themselves broke very quickly if they do that. And so financially, I think they are at a place where engaging a dialogue that says you've got to look broadly, you've got to look at comprehensive community care, you have to look at social determinants of health. So in a nutshell, I think this interoperability collaborative and this discussion of the national agenda needs to be extended globally. So one of the discussion points I would like to just ask all of you is whether you think this is ready for prime time to at least be brought to the attention of the World Health Ministers. And is it time to bring this to the attention of even the lower income countries who would be happy if they could even give health services, but to be saying to them, you need to be looking way ahead. You need to be anticipating, because once you start having a stronger health system, you're going to discover that it is tied to other aspects of social services and life within your country that will, if you don't pay attention to those social determinants of health, you're going to have a very negative, adverse impact on your health, and therefore adverse effect on your health outcomes. So that's why I think this discussion for me is really an awakening, because I have been living for the last few years, or the last 30 years actually, obsessing about the challenge we have in America. And now that we're past Donald Trump, who thought we didn't need to belong to the world at all, as we're back to where we can actually think about, well, okay, the US has a lot to learn from all of these other countries, an awful lot to learn. But can we as a collective also bring this experience to other countries who will soon face many of these challenges if they don't look ahead? So I think I will leave it with that, and hopefully we'll see the discussion here.
Thank you so much, David. So we have time. We have about 15 minutes for discussions. There's two questions that I found quite fascinating in the chat box, and one looks technical, but in fact it's very often a test of the way the system is working. And of course we experience this even more in the central states or provinces of Canada and the US, which is, how do you serve remote communities? And and I think this is a question for Finland as well. You know, how do you serve communities that are not located in big urban area, which I think creates all sort of difficulty in terms of capacity, resources, and so on and so forth. And then there's a question that more at the policy level that I found quite fascinating. And again, that you know, every one of you have mentioned this in a way or another. It's this question about the big system answer. You know, that when you want to integrate things, you integrate the structures, you create a large organization. So what are the benefits of doing this versus other type of organizational models? And I think those two questions are, the one is a test of the way the system works, and the other one is more a kind of philosophical policy question. Who want to start on this? Dave, okay.
I'm sorry, I cannot resist. Looking at these comments, yes. Sonia Kim, first off, on data, I would like two pieces here to say. One is about data. I am very biased by my own organization approach, where we are very data driven. I can tell you right now, every case of trachoma in the world and where it stands being treated anywhere, including the end of the road in some very rural, poor places. So the power of those data is it helps us get to the end impact we seek. So I really think there should be a very strong emphasis on people thinking through data, but related to where are we trying to go? What do we need to know? It's about knowing. And then on the issue of PG systems integration, and the comment is about one big system or company. I used to be an executive at Cerner Corporation, just to be open about that. And we used to laugh and joke about the dark side of integration. Of course, the dark side to big system integration is if it goes down, everybody's down. Everything is down. And that is a huge challenge. There is a very broad upside to it, but there is a cost of being that tightly integrated around one singular system. And that to me is more onto the technology scale of the problem. And the reality is there is no nirvana when it comes to any of these technologies. They're all a pain in the rear. And you will pay the price to use them, but hopefully you get informed in a way that the health outcomes actually justify that investment.
Anu, I would like to hear you on this question because you spoke about this at the start.
Yeah, well, if I understood the first question there right, okay, maybe I'll take the second one first about the comment about how one big system can serve the community care providers. I think that if patients are treated better than they are treated now in Finland, it will serve everybody. Like I said, 300 different IT systems, they won't serve anyone. So one bigger system gives more data, more reliable data. And eventually, I really am naive about this, but I really hope that it will serve everyone, also the community care providers. We have here in Finland, we have long distances here, and people who are unable to access the, for example, they don't have Wi-Fi or internet connections. So just trusting the IT system as the only option it's not we are not ready for that yet. So we need to have other ways too. So we have the smallest municipality here in my area. They only have 700 inhabitants, so it's basically one big house community. But they have a proper healthcare center there too for they people. It's only open for 1 day a week, but we are securing the services also by local services, and it's really thick. Our network of social and healthcare services is really thick in Finland. It's too thick, I think. But yes, there are ups and downs in this, and it needs to be developed in governmental level. So we are sure that everyone is able to and know how to access these systems. There are a lot of mental disorders or really elderly care. We don't expect people to just jump the IT world and use everything, but if we manage to have the 80% of our people which are using only one service, if they use IT systems, so then we can provide to the 10% which are using a lot of services, then we can provide better service for them too. So they are supporting each other.
Yeah, it's a very interesting question, because one of the issues that I've been seeing is that part of what we're doing now is actually amplifying the divide between rural and urban areas. We are actually amplifying differences rather than bridging the type of care and services that are provided in those two worlds. And this is an issue that it is very difficult to address. Bandwidth access, of course, is really a problem for rural areas also in Canada. Afonso, I would like to start with you on the question about Daniel Bach asked a question about the measures related to SDOH. And so, what's your sense of the way indicators are built and used and tracked and so on and so forth?
Can I know that you asked me about the second question, but if that's okay, can I just very briefly refer also to the first question as well? Because I think it's not just looking at the rural areas, but it's more broadly looking at the model of community care. We are now involved, just as an example, we are now involved in a project, which is a social innovation project co-funded by the European Commission to support one of our members, is an authority in a rural area. What we are trying is to create a new model of integrated home care for people with complex problems, and to make sure that they can remain in their own homes, so that they don't have to go to residential facilities. And this involves changing the whole model of community care for those people in those localities, in those rural communities, to make sure that there is a model of community care that provides for them, that supports them, that includes all the different actors, the local actors the communities, the neighbors, and of course that includes technology. So technology is part of it, but it's not the end. It's really is a means to be able to get and to transform that model of care. So we are working, right now we're working on the benchmarking to help develop the model. Then after that, there will be a pilot and experiment taking place for 2 years. And then after that, we will actually work in the identification of other rural areas to exchange with each other and then make a number of proposals across the whole of Europe. And we believe that this is particularly important in the current context as well of COVID, because COVID has made us realize that the model of residential care for older people with complex needs and that need different professionals from different sectors working with them has not necessarily worked in the best interest of those people. And particularly with involvement of a number of stakeholders that were mainly driven by profit and not necessarily by the support of those people who have long-term care needs. So I thought that this is important because the question was whether there was a need for a different approach. There is a need for a different approach in the sense that you need to take into account the needs of those particular communities, but it is inserted in the wider change of the model of community care that we want for those people who have complex care needs that of course need to be provided for in an integrated way, but they may be provided for by different professionals and different sectors. So I thought that that was something which it was important to raise, particularly if we are talking about care coordination across sectors today. The other question,
yeah, briefly, Alfonso, because I want to give other people the chance to. Yeah,
I'm not fully sure about the question in relation to the indicators. I mean, I think that the issue of indicators.
Thank you for calling the town of Northwood. Please be aware that our phones are
I think this is someone with their microphone open.
Oh, okay. I mean,
oh, hi, Linda. This is Chris Tappan. I don't know if my name rings a bell, but we've.
Sure,
I'm good. I'm good.
Chris, your microphone. Yeah, fine. She's muted now.
Okay.
Very briefly, in relation to the indicators, I think that one of the key things when it comes to integrated care, and one of the difficulties is to actually be able to work together to come up with indicators that are common across the different sectors involved. One of the key things that I've seen when we have been involved and work with our members, particularly around health and social care, it actually comes to the fact that some of the indicators were mostly driven for medical reasons, and they didn't necessarily sit well with the indicators that are rather proposed by those working in the social sector, rather concerned with a broader quality of life, more subjective, qualitative type of indicators, and that makes it more difficult when it comes to evaluating. But of course, if we are looking at an integrated approach, we have to take into account both. In the framework of this project I referred to earlier on, one of the key things actually is to come up with a set of indicators which will show us as to whether the person feels happier living in their own homes than they feel, for instance, if they were in a residential facility. But it's something which is complicated, to be honest.
Thank you. Nicole, you spoke about the Alberta experiment at this moment of trying to integrate those indicators in on the same record. Could you go back to this example? And unmute you first.
Yes. So sorry, I was just typing something into Dave into the chat actually, just about the comment that he the question he asked. If I could just address that first, because I found it really interesting.
But you have 2 minutes to do
okay.
that.
So I'll just say, I think it's really interesting and a really interesting opportunity to start for having a social model and health model that can be integrated together from scratch to begin with, because with the most complex patients, the ones who are the frequent users of the healthcare system, those are the ones that have numerous supports in both ends. And we're continuously phoning and talking to the social sector and trying to figure out, you know, who's covering what overlaps with what, where the gaps are, and having the opportunity to identify those potential overlaps before they cause problems is just such an opportunity, I think. And so I just wanted to, that's what I was in the middle of typing out before PG mentioned, wanted me to talk about something else. So I was kind of not super paying attention to what was going on because I was typing that in.
But you made the point during your presentation about this experiment, about building a record that will integrate.
Oh, yes, yeah.
Yeah.
Yeah, so Connect Care. So this is an initiative that started just prior to COVID starting. So it's been put on hold for a little bit, but I unfortunately at one of the hospitals that has been onboarded onto Connect Care. So it's an extremely comprehensive EMR that follows, all of the hospitals in all of Alberta, all of the community hospitals, even clinics will be offered the opportunity to get on board with this and be really kind of pushed in the right direction to use this as the single EMR that they use. And even with my own experience, we've had some patients that have left our hospital to go to very rural areas of Alberta who have also been onboarded into this, onto this EMR. And it's fascinating to actually have access to their chart, just like someone at one of the other hospitals does, and see exactly what's going on, who's doing what. There's a chat function where we can communicate amongst providers between facilities. And it was just just a fascinating, amazing experience to actually see care coordination and experience it on the ground, actually happening in front of me. And I think it actually helps providers tremendously. I've experienced it. It significantly helped and created a lot less overlap in care and services and assessments that we typically do when patients are admitted to hospital. If it's already been done, why would we repeat it? So,
and the striking fact is this is exactly what Anu tried to describe as well, you know, and try with what they were trying to build. And I found very interesting that systems are looking at the same type of solution at this moment. And I think this is in a way very encouraging because it means that we will be able to learn from each other. I'm afraid that, you know, this particular room will self-destroy in 52 seconds. If you have looked at Mission Impossible, you understand exactly what I'm talking about. And I think it was Mission Impossible, but I want to thank the presenters. It was fantastic, very interesting, very compelling, and I've learned a lot during that time. Thank you so much. In particular, Anu and Alfonso, who are in very different time zones than the one in which we are ourselves. Thank you so much for all this.
Thank you, everybody.
Thank you for the opportunity to talk to you. It was really interesting.
Thank you very much, all of you. Cheers.
Take care.
Take care. Bye.